so now we're going to move into the examination of the leg, ankle, and foot. So a couple of key things here. You finish your history, you have a pretty good idea of areas you want to focus on, specific structures you want to look at. You're going to move into your physical exam. You can still ask questions into your physical exam, so don't stop. As new information comes in, ask those questions. Before we start though, I'm going to perform a hands-on assessment. If anything is painful or uncomfortable, please let me know right away, and don't do anything you feel will cause you further injury. Okay? So what does that do? That introductory statement develops rapport with the patient and gives them a framework for what's about to happen. All right? And it's a technically informed consent as well. So if we start from here, what are we going to do? The first thing is inspection. You'll actually look at the feet. And it's one thing to look at the feet just generally with the person in a seated position like this, but what do I really care about? I care about the functional movement of those feet. How do they actually move? How do they change their shape when the person is standing? So the first thing I'll have you do, Amber, is just stand up facing me right here. So inspection, this can be the start of your postural assessment if you want it. And if we can, what I'll do is we'll actually have you stand right in front of this postural assessment chart, something like that. You can look from side to side and look for fallen arches, look for variations in the shape of the knee, and then take it the rest of the way up the kinetic chain. We're going to be specific right now just for the feet. So looking at just the feet, we'll get you back over here in front. So we can just have a look there. So for an anterior view, even just a little bit closer for me. All right, so right about there. What am I going to look at? First of all, I'm going to get low down at the feet. I can't stand it when I see therapists and doctors tell me, oh yeah, I'm doing my foot evaluation from like 6 feet up right over here. You can't see what's going on with that. Get down and have a look. Look at the skin for deformities, bumps. You could be looking at things like hallux valgus, bunions. You're looking for fallen arches, all that kind of stuff. And let's go ahead and have you turn 90 degrees, whichever way you want, doesn't matter. Turns to the side like this. Now I can see the right foot arch fairly well. Left foot arch is hidden from me. You can see the lateral arch of the foot as well, the lateral malleolus coming down, and go ahead and spin again. Posterior view, I like this a lot because it can show you the view of the Achilles tendons, okay, the Achilles tendons as they come down, and you can see the arches fairly well. It's good in this position, okay? One thing I'll get you to do, Amber, is just make this arch a little bit taller if you can. If she makes her arch taller, what happens? It takes the knee and it spins it out a little bit. If the arch falls, the knee immediately rotates the opposite direction. So you definitely want to check those arches and look for that overpronation with gait when you're evaluating the foot. We'll have you turn to 90 degrees again. Okay, finish off looking at the last arch. And that'll pretty much conclude my basic portion for inspection. There's going to be more details with that if I had more time for it, but just right now that'll be our basic introduction. So after inspection is done, you're going to move on to palpation. You've already asked the patient, it's okay if we go ahead and proceed with palpation. Again, just reinforce if it's painful or tender, that's what I need to know. That's what I'm looking for as we do this portion of the exam. So what do I want to do? I want to get down nice and low, and again, check the unaffected side first. The worst thing you can do as a practitioner is the first contact with the patient is painful. What does it do if it's painful?
They just start to distrust you.
Yeah, so you lose patient confidence and rapport if the first contact is painful, okay? So we're going to say she has an issue with her left foot, and we're going to go ahead and assess the right foot to begin with. Basic palpation, you are giving an anatomy lesson of structures below your hand. So you're looking at things like metatarsals, the tarsal bones themselves, coming into the anterior talofibular ligament, calcaneofibular ligament, posterior talofibular ligament, the deltoid ligament across the medial side, long ligament of the foot. I mean, the other thing to realize with this is even therapeutic. A lot of patients find it therapeutic just to squeeze the foot, spread it out a little bit. You're getting sensation, but your sensation of what's going on with the tissue, but your assessment is therapeutic for that patient, okay? What's the standard thing that I'll hear in practice? You can do that for longer if you want, something like that, right? Just to move the foot around and just get a good examination of what's going on through there. Take individual metatarsals and move them around back and forth. See if there's any clicking or pain or discomfort with any of those motions, okay? And like even right there, you could feel a little click that was gone as soon as you moved it around, so just improving overall mobility, okay? Then of course you would proceed to the affected side. So history, inspection, palpation. The next thing you're gonna move on to is range of motion assessment. So for the foot and ankle, not really too much to do here. The easiest instructions I found is to actually use my hands to get the patient to move their foot. So I'd like you to follow the actions I do. If anything's painful, let me know. I want you just to take your feet and push them both down if you can. So she pushes them down, look for motion the same, equal bilaterally, and then all the way back up. Okay? And then you're gonna go back to a neutral position. I want you to turn your feet out if you can a little bit. So invert the ankles, excellent, and then rotate the opposite direction. So evert the ankles, super. Okay, that'll be active range of motion, basic functional assessment. You should be able to give a list of tissues activated, compressed, and stretched when you're doing those actions. Again, thinking of tissue-specific pain generators. From this portion, we're going to move into passive range of motion. Ideally, the best way to do it is to have the person up with their foot off the edge of the table, but just to make it simple, often I'll just do it in this position right here. But for the purpose of this exam, we'll get able to swing our feet just off the edge right there. So for passive range of motion, the easiest way I found to do this, we'll have you slide forward just a little bit. is you want to have the full ankle off the edge of the table right here, and I'm going to, from this position, push her all the way up into dorsiflexion. Now the tricky thing about dorsiflexion, and it's the only joint in the body that has this, when I push her up like this, go ahead and contract your tibialis anterior, she can go a little bit more when she contracts. This is one of the rare joints where it's not in everybody, but in a lot of patients, passive range of motion is actually greater than active range of motion is actually greater than passive range of motion. I could really load into it and push super hard and then go ahead and lift up, and she gets just a little bit more range of motion with that. It has to do with the strength of pull from the Achilles tendon and the gastrosoleus complex and the reciprocal inhibition that occurs when she activates the tibialis anterior muscle group in this area. Okay, so that's going to be plantar flexion, dorsiflexion, all the way down, and give a little bit of a stretch. This is where your assessment also becomes therapeutic. You're increasing range of motion, pushing them all the way forward. Okay. Next thing is going to be inversion and eversion. So inversion all the way across like that with overpressure, and then eversion across this way. Notice that I'm grabbing the back of the foot and the front of the foot to move the whole ankle complex right here. If I was doing a more specific exam, I might switch over into individual bone allotment and movement back and forth like that, but just generally the whole foot is what I'm moving. All right. And those are going to be the main actions that you check right there.
You can also see a bit of a difference if somebody's had repeated ankle injuries on one side. You'll see a difference in range of motion between the two.
Absolutely. I mean, an active range of motion, excellent point, Amber, because you turn in like this, that inverted ankle sprain person will have substantially more motion on the other side compared to this side. Okay? All right. So that's going to be active, passive, resisted range of motion. A couple of key things you can do here. First thing is the best resisted range of motion that I found is going to be an actual functional test with the person standing, but I don't want to quite do that yet. You can check all these things with the person in this position. So holding in a neutral position, I'm going to try and pull your ankle back like this. Don't let me do it. So hold it, hold, and look what I'm doing with my body. I'm leading my full body weight back. I'm not trying to muscle her just with my arms where I don't have strength. I'm trying to keep it calm and use my body weight to pull back. All right? The next thing is going to be plantar flexion. I'm going to try and push you up this way. Let's get you just a little more neutral. Perfect. And don't let me do it. You notice I'm going to get some grip with my foot and I'm going to lean into it, but I mean, these muscles are so strong and this is a significant injury. She can just be slid right up the table with that. Okay? Inversion E-Version, same thing. I'm going to try and spin you this direction. Don't let me do it. So hold, and relax. I'm going to try and spin you that direction. Don't let me do it. This is going to check those everters like fibularis longus and brevis. Hold, and relax. Good. What's the simpler tests for the plantar flexion and dorsiflexion? It's just to have the person do toe walk and heel walk, but we don't have to do that, just really quick. Okay, so that's going to be resisted range of motion. Remember that resisted range of motion gets you into your neurovascular screening. So now you're going to start working towards the neurovascular structures that you want to check, and it's the same for any lower extremity neurovascular screening. What am I looking at there? Deep tendon reflexes, L4, L5, S1. I can do dermatomes, L1, L2, L3, L4, L5, S1. You can also go ahead and check capillary refilling as well at the same time. So that's going to be things like filling the capillaries. Now, you might look at these capillaries and say, wow, those are really red. Of course, it's nail polish, so you can't really see it that way. But it's just as valid to go ahead and take the skin, feel the temperature of the skin, let the hand off, and then watch those capillaries in the skin refill. You're still looking at capillary refill when you do that. I don't know if there's anything else you want to add for that one.
No, just for resisted range of motion, remember to actually put force into the joint. A lot of people don't put enough weight into testing.
Yeah, and in fact that brings up a really good point too for that resisted range of motion. Make sure you develop the force and you develop it slowly. You bring the force on stronger as the patient gets stronger, and then you let it off slowly, weaker as the patient lets
Letting
it off.
it off slowly is just as important.
Yeah, for sure. Yeah, there's been a lot. Every practitioner's had a case where they let it off too quick and somebody jolted or whatever else it is. Okay. All right. And then the last thing is going to be referred pain into the foot and ankle. Generally, what it tends to be, the most common referral into the foot that I see from somewhere else is going to be a radiculopathy. So it's going to be like a lumbar disc herniation or some kind of compressive load over top of the sciatic nerve that's resulting in numbness and tingling into the toes. But it could also be pathologic conditions like diabetes. It could be a diabetic neuropathy, in which case it would be bilateral. Generally, the viscera don't tend to refer all the way down to the foot. It's usually a neurologic issue that comes from further up referring down. And special tests, you're going to pick your special tests based on the conditions that you want to rule in or rule out with the patient, and you can find resources on that in other places.